As far as managing the trauma patient, we have just that golden 10 minutes because we have a whole golden hour that we want to get them into the hospital. Um, so you have 1 to 2 minutes to get that scene size up. Identify your patient priorities and prioritize your workload. You have about 3 to 4 minutes from there to treat any life threats. This is the open the airway, establish the airway, clear the airway, provide breathing, reestablish breathing, and then provide oxygen. Control any hemorrhage before even moving on. Control any hemorrhage, and then think about controlling and managing the C-spine. I mean, this is in line of taking care of the patient as a whole, so you manually mobilize from the get-go. We take the next 4 to 5 minutes, from minute 4 and 5 minutes, to try to package, get them loaded up between 6 and 7 minutes. Within the 9th and 8th minute, we're trying to assess vital signs, reassess any life threats, establish any other types of lines of treatment that we would need, and then establishing some kind of communication, a dialogue with the receiving facility, identifying as far as our trauma patients, and hopefully we have left the scene and departed. During our departure, that's when we would continue on with our management, reassessing our life threats, establishing our second IVs, monitoring our infusion protocols based on our local protocols, and notifying our hospital upon any changes. Now, as we monitor the bleeding, we know that the bleeding is a part of the cardiovascular system. I mean, we have the myocardium and the heart. We have the blood vessels, and we have blood. And it helps us with glycolysis, oxygenation, perfusion. And when we have bleeding, the myocardium changes, the impulses get faster, we have increased metabolism, increased oxygenation demands, perfusion to certain areas gets shunted so that it can maintain blood flow to the core, so that we can maintain blood volume, as well as our vascular changes, smaller capillary beds closing down, arterial blood flow remaining to supply the core functions of the core organs. And knowing that without blood, we can't transport our oxygen and remove any of our byproducts or waste products. And that goes back to our Frank Starling fixed principle, is that the bigger the stretch, the stronger the contraction, and the stronger the contraction, the greater the force. We have the autonomic function coming in, the sympathetic nervous system. We have clotting mechanisms that are starting to work on stopping the blood flow. We have hemoglobin that are trying to attract oxygen and disperse that, and the hemoglobin and oxygen dissociation curve is in place, as well as the renin, angiotensin, aldosterone syndrome system that is trying to control blood vessel size, as well as a fluid being excreted through the renal system. Now we look at normal blood volume is about 90 cc's per kilogram for infant. We look at about 70 to 150 cc's there over. So now when we look at blood loss, if that's total blood volume, and we look at blood loss for infant, 100 to 250 cc's, this is quite a lot. And then 500 for our peds, and at least a liter being significant for adult patients. So our hemorrhage control consists of direct pressure with some type of bandaging material or dressing material. We'd like to put that and dress that real quickly. If the bleeding continues through, we'll go straight to a tourniquet. Now when we place this tourniquet, we want to place this tourniquet just proximal to the laceration of that injury site. And we want to make sure that it controls all the right bleeding, and bleeding stops, no perfusion distal to that area. Monitor distal parameters, identify the time, and mark the patient. Never cover, keep the tourniquet exposed. How do we check for hypovolemia or low blood volume? We usually do tilt changes. These come our orthostatic changes, not just in looking at the patient and determining from the skin signs and external loss, or potential anticipating how much internal loss. We look at also using our tilt changes or orthostatic changes. This is a blood pressure that is taken once they are in supine position. They have to be in a supine position, and after a few minutes, we stand them up, and during that time, giving them a few minutes, we'll check their blood pressure and pulse rate all again. True orthostatics from a supine to a standing position is a 20-point drop and a 20-point increase in blood pressure and heart rate. So blood pressure drops 20 points, heart rate increases in 20 points, or we have an increase in heart rate of 30 points and we're unable to get a blood pressure, or the patient just tells us, hey, I really don't feel great, I can't stand up, I feel like I'm going to pass out, I already have like a near syncopal episode. So think about those and look at our clinical signs. Orthostatics not need to be done if they're already tachycardic, if you have clinical signs of hypovolemia, if you know that there is a significant amount of blood loss. So as we continue on with compressing and controlling the hemorrhage, be advised that anything can be used to control hemorrhage. We have a lot of improvised material. It just needs to be wide. Same thing goes with our tourniqueting. We can use any type of improvised material. It just needs to be at least 2 inches wide. It should be a band that goes around the extremity. This is something that we can go ahead and tourniquet off. And it should be just proximal and tight enough to secure. It's also secured to the limb, and we want to make sure that all bleeding stops. We would have to then continue to dress over lacerated areas, or if there was an area that was avulsed or amputated, we need to control the bleeding at the distal end. All right, internal bleeding. This is all based on your suspect and your mechanism of injury. Again, we talked about the potential spaces. I remember telling you that the cranial vault, it has 3 components: brain, blood, and spinal fluid. It can't cover or contain more than that, unless it's an open skull fracture where the actual cranial material and cerebrum is actually outside or protruded outside the skull cap. We would think about bleeding somewhere else. That would be either some type of external, potentially the neck or extremities, or internal, the internal cages or internal potential spaces. These are cavities for potential bleeding: the thorax, the abdomen, the pelvic, the femur. Again, it's not the cranial vault. I remember telling you that one side of the thoracic cage, 1500, both sides 3000. Intra-abdominal and pelvic regions, massive hemorrhage bleeding can occur. The femurs can hold up to 3000 altogether, 15 in each side. I told you a rib is about 100, lower forearm of the upper extremity about 250. The fractured humerus about 500, and so forth. Solid organs tend to bleed very heavily because of their bleeding, their blood volume, as well as the blood vessels that supply blood to these organs. Sometimes they are encapsulated by their visceral linings, so you need to think about that. But once they start bleeding, it's hard to stop. I may have forgotten to tell you that in the retroperitoneal area, we have another solid organ, and we all know that to be the kidney. That is also a highly vascular organ that tends to bleed out quite quickly. We would tend to see bleeding. This may be late signs. We know them as Kerr's, Cullen's. These are the ecchymotic areas over the periumbilical area or along the flanks. We want to try to control any further loss. We may try to fluid resuscitate our patients with hypovolemia. Do not delay transportation, and I would say give high flows of oxygen concentration during those times, unless otherwise told not to. Follow our local protocols as far as permissive hypovolemia, but do not fall short in establishing those large bore IVs, as those will not impede the treatment once they get to the emergency room and for the trauma care. So we're looking at large bore IVs, guys, in areas where the extremities are not injured, and we can still hang fluid and maybe just not run them.